Right, great. I think we can go ahead and get started. So my name is Shamila, and I'm part of the Mental Health Innovation Network, and I'm the Knowledge Exchange Officer. So I'd like to thank you for joining our webinar today on peer support groups as part of our World Mental Health Day celebrations. And actually, at the Mental Health Innovation Network, we're celebrating it the entire month with a wide range of events and blog series. So in line with this year's theme, Dignity in Mental Health, this week we decided to focus specifically on peer support groups. So again, it's complete with blogs and specifically this webinar. For you who aren't familiar with the Mental Health Innovation Network, our project is a collaboration between the London School of Hygiene and Tropical Medicine, as well as the World Health Organization, and we're funded by Grand Challenges Canada, or the Government of Canada. So MHIN, which is what we refer to the Mental Health Innovation Network, is an online platform which brings together a global community of mental health stakeholders, including academics, practitioners, service users, decision makers, and students, amongst others. We have resources that are generated by those working in the field and are accessed by everyone who is interested in the material, including policymakers who use the information to assist with decision making. So there's a range of resources, and we really encourage you to check it out if you haven't already. And the website is nhInnovation.net. So this event, we'll be hearing about two different projects, one from the UK and another one from Uganda, which works closely with an NHS trust based here in London. But before I go on, I'd really like to thank one of the key driving forces behind this webinar, and the person who actually started conversations about this webinar, my colleague in global mental health and a researcher based at the London School of Economics, Valentina Emmy. So thank you, Valentina. And with that, then, I think we can turn it over to our first speaker. And if you have questions, just feel free to message me directly, and we'll save them for the end, because we'll have a bit of a question and answer session towards the end when our speakers are done speaking. The first speaker then is David Krupezke, who is Head of Empowerment and Social Inclusion at the Mental Health Foundation. A former economist, statistician, and a long-term psychiatric patient, he has been developing, delivering, and evaluating service user involvement in mental health and broader health. Advisor to the WHO on empowerment and led the development of mental health empowerment indicators for WHO Europe. With that, then, I'll turn it over to David, who will speak about his peer support groups project. Yeah.
All right. Bear with me 2 seconds while I flip up my presentation. Can I check that's visible?
It's working for me.
Well, thank you.
Yep.
Okay. Welcome, everybody. Thank you for giving me this opportunity to present some of the work that I've been doing around self-management and peer support based here at the Mental Health Foundation in the UK. This is what I'm going to cover in the next 15 minutes. So I'm going to talk about my background and experience. I'll talk a little bit about the journey that we've made in support. We didn't start with support. We started with self-management. and I'll explain a little bit about how we moved from self-management to peer support. Then I'm going to talk about what we've actually done and achieved in our peer support project. I'm going to talk about some of the underpinning values and principles that define how we, our self-management and peer support, the things that we've learned along the way, and some of the things that we're doing now and in the future. So, to start with, my background, I had this strange dual background. So my professional training is as an economist and statistician. But while I was growing up and training and indeed working as an economist and statistician, I spent a lot of time going in and out of psychiatric hospital as a patient, entirely in England and Wales. And by the time I was 20, on the one hand, I had a degree in economics and statistics and was writing economic models for our treasury. On the other hand, I had acquired 6 different psychiatric diagnoses, received 22 different types of medication, and been detained under 2 different sections of our Mental Health Act. I'm struck by the complete difference in attitudes that people had towards me, depending on whether they were considering me as a professional or as a psychiatric patient. And one of my driving ambitions as a result of those dual experiences was to try and work towards people with a psychiatric diagnosis being treated as equal citizens. And I still think that's one of the things that drives me and my work, and indeed the work of the Mental Health Foundation. So we'll also just mute my other computer, which is binging away in the background with me. That. So, as I say, we started with self-management, and the work we were doing really was trying to build on the excellent work that's being done in long-term health conditions, where historically people's health has been managed by doctors on their behalf, and certainly more recently, we as citizens have been both expected and encouraged to take a much more active role in our own health and well-being. And this is not just in terms of prevention and lifestyle, but in terms of active condition management. So there are strong evidence-based models for in things like diabetes, chronic management, arthritis, and other long-term health conditions. There are quite a few different models, and they have a different focus. So a lot of work has been developed by Stanford University, which you might characterize as condition management. So the focus is on how you manage a particular condition that you may have. And there are psychoeducation models, which are about understanding your condition, and there's been some very good developments in Barcelona. And those tend to have a focus on with a particular condition or diagnosis. And one of the things that we discovered as we were developing our work was that although this worked pretty well with some conditions, it was not working very well for all conditions, and it was particularly not working well as an approach for some psychiatric diagnoses. I think we discovered 3 reasons why that might be, and if I have time I might come back and talk those a little later. So the idea of our intervention was to develop a psychiatric equivalent for the work that had been done in other long-term health conditions. We discovered that that was actually the wrong kind of thing to do. And self-management tends to be quite an individualistic thing to do about you, your health, your condition, and your life, probably in about that order. And what we discovered we wanted to do was, or what we discovered we needed to do was set this very much more in the context of people's lives, but so in the context of their relationships with other people. So we started off with self-management. We moved rapidly away from this idea of condition management. Our focus became on goal setting and problem solving, but we quickly learned that the only way to do that effectively was not as an individually focused thing like self-management, but as a much more collective endeavor, what we came to think of as peer support. So what I tend to do now is I tend to talk about management and peer support as a single phrase. We talk about peer support. There are several things that are worth defining. Firstly, we are talking about working towards people's own goals. Although we're talking collectively, the goals people set are goals people set for themselves. They're not set for them. They're not clinically set. They're not necessarily symptom orientated. They can be any goal you like, and I'll talk about some of the most common goals people set. But they're people's own goals. They own them, and they set them and try to achieve them. But the way to do that is by articulating those goals collectively. So we, in the UK, we have this tradition of New Year's resolutions. I don't know whether these have international validity, but every year in January, we sit down and promise to be better behaved this year than last year. And what we know is that if you set a New Year's resolution, the most likely thing that will happen is that you will fail to achieve it. If you articulate that to other people, you have a much greater chance of succeeding. And work collectively with other people to achieve that goal, you have a much better chance of actually achieving that goal. So, although the goals are individual, we ask people to work on them as a collective endeavor. Also found that because people are sharing their goals, they are better able to support each other to help meet those goals. So because people have a lot in common, the 8 peer groups, the goals people set and the problems they face achieving them are usually common amongst the peer group. So a problem that one person faces in trying to achieve their goals is quite possible and likely that other people will have faced that problem and can share the learning about that. In short, what we have found is that self-management gives peer support a sense of purpose, and peer support makes self-management more effective. And we think they have a strong symbiotic relationship with each other. So this is what we actually did. We developed, having looked at a lot of things that were called self-management, we developed our own version of it. It is now a manualized intervention, so we have written it down. We've produced something that can be delivered in a standardized way. We were fortunate to get a substantial amount of funding from our lottery, the equivalent of a little over €1 million, to develop and deliver this intervention. And the way we developed it was to bring together some between 20 and 30 people who were using secondary mental health services. And we worked together for 4 days as a residential workshop in a hotel in Wales. And what came out of that was entirely produced by people, all of whom had had experience of using secondary mental health services. We then did a lot more consultation work with the ideas that we'd come up with, culminating in two pilots to run this in real time. And that whole process from the funding and to start it through to having run 2 successful pilots took approximately 12 months. And the manualized intervention looks something like this. This training in goal setting and problem solving, followed by 6 half-day sessions in which people talk about their progress towards goals, the problems they've faced, they share those problems, and they try and collectively overcome them. Sometimes that involves reviewing and changing goals. Sometimes that involves having achieved goals. And then following those 6 half-day follow-up sessions, we had regular peer support group meetings for the next 6 months. So that, in effect, is what we think of as intervention. Over the period of 3.5 years, we ran 62 courses. We trained over 650 people. All of the people who went to those training sessions, as described, had used secondary mental health services. That is to say, they were people who were getting mental health services above and beyond just through family doctor. So they put bluntly, they almost certainly had a named psychiatrist and are working with a mental health team. Also, once we had a stable intervention, we reviewed it regularly, and once we had a stable intervention, we started an evaluation. We've already met Valentina Yemi for her contribution to this seminar. Valentina helped and indeed led some of the evaluation of this project. She is familiar with it, and at the end I'll give you some peer-reviewed paper references that you can look at. But we evaluated it against well-being, healthy living, and cost-benefit analysis. And this is what we found. And again, those are the references for people interested in looking at the papers. There are drafts of those can be freely downloaded from a website I'll give you at the end of the presentation. We found significant improvements in mental well-being using the Warwick-Edinburgh Mental Well-being Scale. We've found significant improvements in healthy living using the Healthy Lifestyle Profile 2 instrument, and we found potential for cost benefit. The research did not have a control group, so it is not possible for us to definitively attribute the benefits to our intervention. Although we were very fortunate to have lottery funding, our lottery is very good at funding interventions that are new, innovative, but it does not fund heavy research. So you would not be able to get funding from our lottery to do a clinical trial or to run a control group. So that is something that we need to do with further research. One thing that we noticed in terms of the benefits that we did see was that the benefit we tested at start, at 6 months and 12 months. And in well-being and healthy living was significantly improved at 6 months, but better still at 12 months. So unusually for an intervention that is training-based, it actually seemed to get more useful over time rather than tailing off over time. So then that's something we would want to explore in a little bit more detail. Then some of the informal findings. The 60 tips that we ran, some continued functioning for a long time after we stopped working with them. Some didn't. But those where the members of the peer group had a lot in common, the more they had in common, the better the groups appeared to function. Facilitators, all of the facilitators were people who were prior course participants. So apart from the very first pilot, which I co-ran, every course was facilitated by someone who'd either been on that first pilot or had been on a subsequent training session. But our most effective facilitators were not those skilled necessarily, but those that people thought they could identify with. And in particular, one thing that was said time and time again, someone I could be like in 6 months' time. In terms of the goals people set, the most common goals were losing weight, giving up smoking, exercising more, being more healthy, being more qualified, getting a job, improving my education. There far more of the goals were life-orientated or general health-orientated. Very, very few of them were condition or symptom-orientated. And that wasn't what we were expecting, but that was a very, very clear finding. The underlying principles, I'd like to thank Jolie Goodman, who has helped with the artwork. She facilitated some of our courses and is a great artist. And she has encapsulated some of the principles of our work in pictures. So the key principles are that the work that we do is life-orientated and condition-led. So although all of our people on this course used mental health services, the training and the goal setting was really much more about their lives than their conditions. As I've said a little earlier, all of our trainers were people who were participants, and the goal setting was absolutely fundamental to what we do. When we talk about the active ingredient, if you like, of our intervention, the active ingredient was goal setting. That was what we really wanted it to do. And that's a copy of one flip charts from one of our sessions with some of the goals that people set. And in addition to the recorded benefits through the evaluation, there were some key findings. Some things people said they really liked about it were a sense of achievement, chance to help other people. And this is a big thing for us. Those of us who've been psychiatric patients, we are nearly always cast as the problem that needs to be solved by other people. And this was very often the first chance people had to be cast in the role of helping others. And people clearly found that to be hugely beneficial in itself. So being part of a group and being able to help other people were some of the key benefits. And what are we doing now? As a result of this work, we have developed two versions that have a different focus. So working directly with single parents, working directly with prisoners. Again, not specifically around mental ill health, but with groups who both have very high risks of mental ill health and high levels of mental ill health. We are also developing versions for people with learning difficulties and people in a variety of other settings. For people who are interested in more information, those are my contact details. You're more than welcome to email me. The research papers I talked about can be free downloaded from my personal archive at www.peersupport.info, and our organisational website, the Mental Health Foundation, can be found there. I think that's probably just my time, maybe a little bit over time, so I do apologise for that. And I will now try and hand back to Shim.
Great. Thank you, David, for your insightful presentation on self-management and peer support. And it was really great to hear that the findings were positive and promising and also very cost-effective, so that's really good. So before we go on to the next presentation, can I just have everyone please mute your mic so we can sort of get rid of some of the interference that we've been hearing? That'd be great. The next project then we'll hear about is based out of the user-led organization Heart Sounds Uganda. And we have 3 speakers with us today, and we'll first hear from Serdik and then 2 experienced peer support workers, Benon and Eddie. Serdik has been working in the field of mental health for more than 25 years. With experience as a young carer of illness itself and as a nurse, he's been privileged to work in Australia, the UK, Uganda, and Gaza. He has had many roles offering clinical, training, and development support. However, he currently works in North London as a nurse consultant, meeting the mental health gap with local GPs. He has a particular interest in peer working as a route to a more humane and empowering approach to mental health care. He worked with the Budabika East London League since 2005 to foster the user-led organization Heart Sounds and the country's first mental health peer working scheme and recovery college in Uganda. And after that, we'll hear from Benon, who is an experienced peer support worker who has risen to a leadership role within the Brain Gain program and is working as a coordinator to develop the first African recovery college in the grounds of Budabika Hospital in Uganda. Then from Eddie, who is the project finance officer for Brain Gain 2 project in Kampala. Edward has experience of both UK and Ugandan mental health services and has brought his enthusiasm and experience in his leadership role within the Brain Gain program. So with that, then, I will turn it over to Serdik. Ready, go ahead.
Lovely, lovely. Everybody, great to see some familiar friends there, friendly faces, and I missed some of what you said, David, because I lost my signal here in North London. So I think in Uganda you're doing better than I am at the moment with signals. So I've got to tell a little bit of the story and a little bit of some of the learning from it as well, and some of the hopes for peer working in Uganda, because it feels like a special story and quite unusual. I first visited Uganda in 2005. I was working with East London Foundation Trust, and the opportunity to be part of this link with Budabika Hospital was something that came with the work I was doing. And I went over for a drug and alcohol approach related to some training I was delivering, and I started to visit some of the wards of the hospital, and pretty horrifying, I think, from my perspective. I felt like I'd been quite sheltered. It's a pretty humanizing circumstance for people to find themselves in. People are in green uniforms, there's guards. At the time, there were guards who would have guns and would use them as well. And really kind of dehumanizing conditions, very much, and also quite overt stigma against people in the community, particularly people talking in very disparaging terms about people with mental health problems and who they were and what they represented as well. And so that was a real shock to me. But the thing that really stayed with me was that I started to meet some of the people in these wards, and they were enthusiastic and skilled and had massive aspirations and a voice that really inspired me to get on board with the possibility that change might happen, with them being in the driver's seat as well. And they really just saw me on with their own enthusiasm to make something different. And so I think where we started to sort of develop relationships with specific people and to know the different people who were using services there. And in 2008, we took over a group of service user champions, for want of a better term, which were people who either were using services or who were championing user leadership in the UK. And we took that small group of about 8 people over to Uganda to meet their peers. And that was a moment in which the two kind of groups came together and increased the credibility of the user voice and the importance of the user voice as well. Because in the UK, you looked up to as an example of good practice as well. And so people were really struck by, well, you have users in leadership roles, what's that about? And that provoked a lot of conversations and a commitment from the Ugandan end, from health professionals, to do something more. And so Budabika Link then started to focus on building the skills and the opportunities for people who are using services, and things like learning how to run focus groups, participating in commenting on project development and helping design projects started to happen, and gathered together around real leaders, people like Joseph Kunda and Eddie, who you're going to speak to, and Rubina Alambuya as well, and more, came together around Half Towns Uganda to act as real advocates for the voice of services within the mental health service in Kampala in particular. At the time, I was doing some training in East London for peer support work development and also helping support some new peer workers who are working in inpatient settings. And I too also share information about what I was doing, because I was really struck that what's the possibility of peer support work in Uganda, and we started to have discussions about it across a website that had been built around the trip from the UK people to Uganda. And that idea threw up the possibility of peer working in Uganda, but also the reality that it was already happening in many ways. And people realised that this was a way of providing support that really fitted in with what people wanted to create in their communities, and a real vehicle for advocacy as well. This led to the Brain Gain 1 project, which was the first peer support work project, which ran 18 months with about a year's worth of peer support working, which was primarily in the community, but with once health workers kind of got to the idea of peer workers working within mental services, there was immediate demand to also bring that into the hospital as well. But it was from the community, and that group of 29 peer workers, incredible amount of visits. They did something like 500 visits at the time, and they're probably in contact with 4,000 people in different settings, providing some kind of peer support work and peer contact. So that was incredible, from going from no service to this incredible service that was really inspiring to a lot of people. And that led then to the Brain Gain 2 project, which we're currently in the middle of, was also locating peer work more formally within existing mental health services in Uganda. So that's the kind of story of where we're going to, and Brain Gain 2 is very much more of a research component that's very strong. Brian from the London School of Tropical Medicine, I never quite get that right, is really doing very shared work with service users and professionals to create a research program to measure whether or not peer working has the impact that we think it has. The measurements we did post the first Brain Gain project showed peer workers themselves got a lot of gain in terms of esteem, in terms of challenging both internal but external discrimination, as well as benefits to the people who receive the service. Really talking about the importance of role models and the importance of advocating for their voice and their life. So it was really interesting to hear David talking about very life-oriented, and people really that sense of being met on their own terms by peer workers rather than being met on very medicalised terms, which is the tendency in the UK also. So I kind of go through a few of the key learnings that I've been thinking about in relation to the Brain Project, which has run over a sort of 6-7 year period in total, that whole process. There's something about people who use services and have a lived experience of mental health problems, given the opportunity and the right support, can do the work, can make this happen, can be in key roles. And I'd really like to stress getting the right support. I think the people in the Brain Gain 1 project who were in leading roles really lived under not get quite enough support. That's like training, but also space and flexibility around how work happens. So that's a challenge both in the UK and Uganda, I think. There's also just a really important point is that people have, given the opportunity, people will take that opportunity and they will do really well with it. I can't see enough opportunities out there for people to lead and design these programs. A low-income setting like Uganda, where employment is massive and the access to learning and money is also so much more restricted, the second benefits of massive. So to peer work, you've got employment, economic opportunity, you've got esteem, recognition, then it'll have an impact. Also mentioned this idea of a grassroots approach. This program was grown out of a kind of co-production of ideas around what can we do together, working together on trying to figure out what needed to happen with user leaders in many different forms, on the net, on the phone calls, but in person as well, and generating the ideas that became the Brain Game project and the peer support program. It feels like there's a real danger that when peer working gets formalised within a mental health system, it starts to get taken out of the hands of the peer workers themselves and the service user leaders as well. So just really, it's a warning for me about the importance of continuing a kind of co-productive stance all the way through. The thing I really learned is that Ugandans have their own view of recovery, and it's not necessarily the same as a UK version of recovery. There's much more emphasis on things like discrimination, on spirituality, and the importance of advocacy at all levels, both local as well as governmental levels. And it has a resonance with BME communities in the UK, and so I think that's really important. Just a couple of challenges as well. Well, there's many challenges, but some of the most important perhaps. Again, just without the right support, user leaders are likely to end up in either conflict with each other or burnt out. I lost Rashid, who was one of the advocates of the Heart Sounds Project. He died, and he died in hospital, and I think just as a real reminder that it's actually physically dangerous for people to be in the mental health system, or out of the mental health system for that matter, and so we really need to protect and nurture people who are in those leadership roles to make sure that they're available to be there in the long term rather than losing that talent very early in their lives. So one thing, also I'd say institutional blinkers. There's really good people, health professionals, forging on in really impossible circumstances from our perspective, perhaps the UK, and that's to be recognised, but I also think as you move up higher levels, there's less direct contact with people who have lived experience of mental health problems, and what you get is a kind of people used to quite an unequal relationship and not advocating for that to change, and so really trying to remove the organisational blinkers so that people with experience are at all points of hierarchy and in positions of power to make decisions feels really important. And I'd say that needs to happen within research bodies as well. There's a lot of doing too, and there's a lack of opportunities for people with experience and use of services to research skills. Lack of investment in mental health, as we know, and some of the conditions, particularly in some African countries, are just abysmal, and really needs to be advocacy at a very high level to change that. And it needs to be with lived experience doing that advocacy as well. I know some of the Heart Sounds group do that already, but I just think it needs to be extended more, and we really need to push for that wherever we can. Just professionalising peer workers. There's a real feels like with peer workers that what we do is peer workers get changed into kind of mini psychologists or mini nurses, and actually there's a kind of magic, and there's these magic ingredients, and I think, David, you alluded to some of them as well. You directly spoke about some of them as well, and the danger, I think, that we might lose some of the magic by just simply getting people to deliver interventions without, in a way, allowing things to develop and grow with a kind of range of skills available. So keeping things flexible enough for people to meet people's terms and use the skills and use their own experience as they need to. But there's just a little thing that I've in Uganda around the professionalisation. There needs to be some way to grow peer work from their applied expertise rather than feeding them like some kind of, mass production dairy cows, just doing the next thing, the right intervention. I think it needs to be a little bit more flexible, a lot more flexible than that. So I just want to give a couple of one is experts by experience and profession. High-income countries, how to do things with the low-income setting. Ugandan peer support workers are really showing that how to be done, even with few resources. There's a real lesson for us in the UK. Learning will come back to the UK, and I think there's plans afoot with the Brain Game project to do that. peer workers will change the culture of care in Uganda. Elsewhere too, I feel like there's a real opportunity for a more evolutionary approach to healthcare. I think we failed with a medical model, and we really need to take on board what the expertise of peer workers says needed. Finally, I just want to see research and development leaders really providing those opportunities that people with lived experience need in order to get to both the food chain but the physician change as well. So that's my summary of highs, lows and challenges, and I hope I can feed into the discussion. Thank you. Now I need to know how to put this on.
That's fair, Dick. I think I've already sort of done it, so that's fine. Thank you so much for your presentation. And with that, then I'll go ahead and play the video that we have that has a presentation from both Eddie and Benon. So do me if it doesn't work, because I won't know if it will or won't. So I'm just going to go ahead and play it. Okay.
I joined the Brain Gain project during the process of peer support work, and that was in the Brain Gain 1. I was referred by a psychiatrist who was working in a medical hospital, referred to Heart Sounds Uganda, and at that time Heart Sounds Uganda was managing the Brain Gain 1 project in cooperation with the medical hospital and the Eastland Link. So I was touched by peer support work called Rashid, unfortunately in person. So he offered me support during the Brain Gain 1, and given his support, I was in link with the Heart Sounds Uganda, got a job, and I started volunteering as an assistant accountant, and this empowered me so much. This time, given the little earnings, I was able to start living independently, renting a house, and thereafter I was then enrolled to start training as a peer support worker. And really after that training, I also started giving support to other peers within the country. Brain Gain 2 project, actually Brain Gain 1 was not sustainable, given the fact that after the project ended, peer support work as peer support workers, we could no longer continue visiting our peers in the community, given the fact there was no funding then. So with the Brain Gain 2 project, we are now back on the ground offering peer support work right from the wards in the Watabica Hospital and reaching out peers in the community. We do peer support work both in the hospital settings and the community. And there are so many challenges that we really encounter as leaders to make sure that these things happen the way it is planned. You find that time was linking up with peers in the community becomes difficult. You can visit a peer when the work, but at this stage you can lose contact of such a peer. Maybe some peers escape and you cannot locate them in the community. So it becomes something so difficult to make sure that we empower our service users to our expectation needs as we planned in the beginning. Yeah.
I happen to have got the opportunity of being exposed to user involvement outside the country, in particular in the UK, where it was also in its embryonic stage starting on, and the user service user leader. When the trusts were turning into foundations, and it was a right for trust to be user voice on the board. So that helped me. It gave me an insight and background on how to develop user voice in Uganda when the time came. Opportunities in Uganda and although there are some challenges all stretch back from the beginning of the training schools and the medical school, which are based on a medical model. So when trainees come out as professionals, don't have any background of a recovery model. They are based on a medical model. So when it comes to users a voice to their involvement, peer support, task shifting, task sharing, co-production. It is quite challenging to have them harmonize and take it on board. That is one of the things that could be a hindrance, because the curriculum needs to be revised in the training schools and the school. Opportunities are many, because users will get a chance to get a link which become meaningful and gainful as we go along. Opportunity for user involvement in the country are enormous, because first of all, a significant part of the population challenged mentally, and this being a question of, say, every 4 of us have got that condition. So people to do the user involvement are available, are able to do it, and very effective. Although just like stigma to make people shy away and keep in the background, propping up nowadays again, and this needs to be addressed. So people could do peer support in hospital and the community, but also in the community where there's a lot of virgin opportunities that are not exploited, because much of the treatment that is custodial, that is, it is hospital-based, but taken to hospital against their will. So find that it in the community would be more appreciated if that could be tapped in. So this could be to the insurance companies which don't have health insurance for mental health. My health insurance card is meaningful to me when I get a relapse. It can help with me. But care support can be useful to fill up that gap by offering support and talking therapy to the patients in the community. It's developed and more professionalized, because it is funded and it is entrenched into the system. But in Uganda, it is more or less growing and up slowly by slowly, and it's not yet funded. It is a big hurdle we have to go through to prove the case that service users can be useful in contributing to the care and the services of the hospital, in promoting care by co-producing and co-production. But in the UK, it is funded, it is highly promoted, although challenges are along the way when it was started. It has to be accepted that Uganda will also face some challenges.
All right. Concludes the second presentation, and I just want to say a big thank you to all of our speakers, especially on sharing both the benefits and challenges of working in the field, and also sharing the benefits of moving away from the medical model to more of a holistic recovery model involving many different stakeholders as part of the global mental health community, sort of kind of what we're working on as well at the Mental Health Innovation Network. So with that, then I think we can spend about 5 minutes on questions. If anyone who's tuned in has questions, there was one that was sent earlier, so I think we can get started with that one. And if anyone else has questions, just please feel free to send them my way using the chat function. So the question that had come in earlier was, has there been a role of motivational interviewing in peer support work? Projects that you've been working on?
Not in our one. Technique we have come across, but I think because this is entirely led from within peer groups, it would not follow that particular structure. I think it certainly drawn on a range of techniques, including that, and including techniques that would be common in a range of both therapeutic interventions like CBT or behavioral ones, but also quite commonly drawing on things like mentoring and life coaching as well. So I think we have shamelessly taken our inspiration from anywhere we can get it. to make this as effective as possible, but not with any particular approach dominating. And I think that's why we thought it was important to realize the intervention so people could see exactly what we've done.
Great. Okay.
If I could just add a bit in terms of the Uganda experience around motivational interviewing, it was kind of infused in the training in that it was used to explore different questions, different ways of weighing up pros and cons without necessarily imposing a particular view on people that things have to be a certain way. And so in the same use, from the kind of narrative therapy approach, stories are really important within worker development, it feels like, because it's something about that story is one of the keys about how it's communicated to other people, but also that it's almost like the story itself needs to be reframed in a way so that it's that it's a good thing to reach out with that story. And also I'm conscious that the Ugandan also had some CBT training as well. So in some ways, I think people have been foraging quite widely for lots of different skills, but it hasn't kind of been brought into you need to then deliver that. It's more people have a kind of toolkit that they make use of. But it's a manualization around that needs to happen as well.
Thank you. And I did forget to mention that we have Eddie with us today. Benon could not be with us today, but Eddie is here. So if you have questions for him or for any specific speaker, just feel free to send them. I have one directed to Eddie, which is, so Sertic talked about the opportunity and the right support for peer work to flourish. Can you say a little bit more about what that might look like? Eddie? Sure. Sure whether he's able to hear me. You maybe say something about that until I figure out what's going on with Eddie's mic.
Can you hear me?
Oh, Eddie, yes. Did you repeat the question?
Yes.
Okay. Yeah, so the question was, Sertic talked about the opportunity and right support for peer work to flourish. Can you say a bit more about what that might look like?
Opportunity for peer support work to flourish in the country is possible and actually because, like John highlighted in his video clip, that when he got in touch with Hudson, the peer support group, he was able to get independent living and was able to rent himself premises and get a meaningful living, and he felt rewarded and he gained meaning in life. So that is an opportunity that can be achieved out of peer working. But also, it's also possible to flourish because there is a significant number of people who are challenged with mental illness. And so when it comes to peer working, there's a source that can be tapped, which has previously been untapped, and it could be useful in bringing a contribution to services in the hospital, especially with regard to the recovery model.
Great. I had one other question about the tree life resources that Sertic mentioned. Could you perhaps signpost the group where those could be found? The Tree of Life resources that Dick had mentioned, where could those be found?
The website of Tree of Life, I think Sertic can help me with that. The website of Tree of Life is somewhere. Sertic could help us with that website. David Embra, is it? I can't get it offhand, but there's a website which people could get training in. Website is particularly in the UK. but in Uganda we received training in Tree of Life, and I've used it in kind of leaves that we have when we are doing peer support visits, in a way of boosting people's esteem to feel that they could get hope, they could get future aspirations and insight into their background to inform their future.
Wonderful. So do you have the website?
Can I have a question, Eddie? I don't have it right here, right? I wanted to
Like
tell you
David
about
Embra. I think it's on the Hacksound website. Did the Dulish. I can't say that. Can you again?
Your views on what support would help you to be a peer leader in Uganda? What kind of support needs do you have, whether it's training or support from other people or financial, or what is it? I mean, I'm interested to know what you think would be the ideal support you would get.
In regards to things like the community of practice, where we have the recovery colleges, international recovery colleges coming into in-person meetings, exposure to such forum would be helpful to show me practice that has worked elsewhere, and also having exchange visits. We've had so many inflows from the UK, but very few visits from Uganda to UK or elsewhere. That could help. So basically, we are trying to do something that is not being applied or worked here before. So we're just picking our brains. We need to get insight from where it has worked, where it has succeeded, so we can blend it with what works here to something that flourishes.
Okay. Any other questions? Okay, so I think we can go ahead and close. I know Matt has sent a message to everyone, and I just want to go ahead and allow just in case you haven't seen the message. So there's a free Recovery Research Network meeting on implementation in Cambridge next week. So if anyone is in the area and would like to attend, there's a link available in the chat area. If you have any other questions that you didn't get a chance to ask and would like to ask the speakers, please email us at mhin@lshtm.ac.uk, and we'd be happy to connect you with the speakers. And with that, I'd like to thank you, the speakers especially, but also those that have attended for such a wonderful talk on such an important topic. And hopefully we can keep the discussion going both online on our website, through our forum section, and as well as our social media channels. So hopefully you enjoyed the event, and if you do want to watch the webinar again, we will have a link available in the next 2 weeks. So thank you.
Thank you, Mela, for all your hard work in getting that together.
No problem. Thank you so much for presenting. It's really good.
Pleasure. It's a pleasure. If there's anything else you need from me, or if you, please let me know. And at some point, when I have an idle moment, I will get around to submitting my innovation thing,
Yeah.
which I think you see all the forms. It's just on my very long to-do list. So.
I absolutely understand. That's fine. Initially, I was like, it would have been perfect to have it up.
It really should have been up and running by now. Yes, absolutely.
No, I absolutely understand. So take your time, and if you have any questions, just feel free to send them my way.
Of course. Lovely. Thank you very much for your help.
No problem. Thank you, David.
Bye.
So who's next? I see you in Joseph. I just want to say hello to you while we have a quick chat.
Is around?
Yeah. Do you hear me?
I want to see you. Let me see.
See what?
You on here.
not on video. I'm having these old Link computers, the old ones. They don't have.
Oh, I see that Kim is with us. But it seems she's not on.
Your phone's not working.
How are you able to hear Sadiq talk?
No, here, Sadiq. I came at the end and I was having trouble signing in.
You link that I sent you on Skype?
Yeah, it's what helped me. Yeah.
Sadiq, I think it was important to highlight that we need exposure so that we get to know what we're doing. Like David said, Joseph has already mentioned it, that we really, when we get it right, we've not done it, we've not seen where it has worked before, we don't have anything to compare notes with. So exposure will really help to enable us to do the leadership well.